So during our last presentation, we discussed the proximal convoluted tubules, and we mentioned that this part of the renal tubules reabsorb a high concentration of water as well as most of the ions, but it reabsorbs 100% of amino acid, glucose, and vitamins because there is no other channels or means to move these three components, amino acid, glucose, and vitamins, through the rest of the tubules. So PCT is the only place that you can have reabsorption with these three components. Now, if you guys remember from the PCT, we start to go down and utilize the descending and the ascending part of the nephron loop. It mentions loop of Henle. Loop of Henle is the same thing as nephron loop. It's just the name of the person, again, that discovered it. So during the descending limb of the nephron loop, the only thing that you can reabsorb is going to be water. So about 15% of the water will be reabsorbed here, either through transmembrane or paracellular transport, paracellular or cellular transport. We can move the water from the filtrate back into the peritubular capillaries. But the very important component of the descending limb is that it is only permeable to water, but no solute can pass through. That includes all of the ions that we have inside the filtrate. However, on the ascending limb, what you have is you have inability to reabsorb water. However, you're going to be permeable to basically three main ions, which are your sodium, chloride, and potassium, and the other ions through the paracellular mechanism. So looking at how I reabsorb these three ions, we're going to look at the picture. So here is the picture. Let's orient yourself. So right here we have the filtrate. We have the cells that are lining the ascending limb. We have the interstitial fluid. And right here we have the peritubular capillaries or vasa recta. In this case, vasa recta. So what you have here is you have a symporter. So again, sodium is going to be the driving force for it. So here is the thing, a symporter. So sodium is going to be the driving force. So one sodium is going to come in. And as you move the sodium in, you're going to move two chloride and one potassium in, but against their concentration gradient. So these two are going to be against, and this one is going to be with its concentration gradient. So now you brought these three ions in. So what are you going to do with them? Sodium is going to use its sodium-potassium pump, which you see right here, to basically be moved into the interstitial fluid and eventually into your vasa recta or peritubular capillaries. Chloride, as you can see right here, is going to move through its leakage channels, which is basically what it means is facilitated diffusion. And potassium, on the other hand, you have leakage channels, but on which membrane? This is an apical membrane. So the apical membrane is where you will have, I can't spell. Okay, so apical membrane is where you can find the potassium leakage channels, which means potassium is going to basically flow back into the filtrate. So looking at this, you also see that a lot of the positive ions that are listed here are moving through the tight junction to get into your capillary network. Notice that if you guys remember from our previous lecture, we said chloride is going to attract the other positive ions, right? So when I move chloride, the negative is going to move in faster since we're moving two of them. And that's going to attract a lot of the positive charges to also be moved from the filtrate using the paracellular mechanism into your blood vessels or into your capillary network. Now, kind of going over the distal convoluted tubules, it is one of the parts that basically decide what your body needs, and based on based on the requirement of the body and with the help of collecting duct, it can choose what your body is reabsorbing. So up to this point, which is PCT, ascending and descending limb, you reabsorb majority of the material that are present inside your filtrate, including ions, water, bicarbonate. However, the DCT and the collecting duct together are going to determine the need of your body. So if you need to take something more than usual, or you want to remove the extra ions, then DCT is the part that is going to make that decision. So one of the most important components that's going to affect your DCT is the parathyroid hormone. And this parathyroid hormone is going to be released from your parathyroid gland. So parathyroid hormone, and we'll talk about this on the PowerPoint for fluid balance, fluid and electrolyte balance. But parathyroid gland, which is located on top of within your thyroid gland, is going to produce PTH, which is parathyroid hormone, and by that you can increase the calcium reabsorption back into your system. So this scenario where I have this, it only happens if my blood calcium is low. So there is one way for me to basically adjust and help my body recover what I might need using your distal convoluted tubules. You also reabsorb by this time about 90 to 95% of water and solutes back into the system. And some of the ions that you have are going to be reabsorbed based on the need. For instance, you have a specialized cells, and I'll mention that. We don't discuss the cell, but there is a hormone called aldosterone that's going to allow an increase in reabsorption of sodium, and it causes a decrease in potassium. Sorry, it causes an increase in potassium secretion. So you're going to increase sodium reabsorption and also increase potassium secretion. So basically you bring one ion in and you kick the other ion out. We also have scenarios where you have basically an acidic blood where you increase both potassium and bicarbonate reabsorption and you increase the secretion of hydrogen ions. You can ignore the last bulletin points. But again, the idea here is that DCT is going to act as a balancing component that basically allows you to reabsorb components or remove components based on the need of the body. One of the other ones that are not listed, but I will discuss them in detail later on, is ADH. ADH is antidiuretic hormone or vasopressin, which controls and help with basically reabsorption of water. So reabsorption of H2O. So up to that point, you reabsorb water based on basically what your body have to take back, regardless of how much water you have drank. But in the DCT, in the presence of ADH, you can even reabsorb water at a higher concentration. Here is the scenario I was describing in a sense of aldosterone and specialized cells. So in this scenario, you can see that your body is basically taking in sodium. So sodium is just easily moving in and diffusing in using its leakage channels. And potassium is being excreted out of the system or back into the filtrate using leakage channel as well. And then you have right here, you have your sodium potassium pump, which basically, or sodium potassium ATPase, which is using ATP to move sodium back into the blood and potassium back into your system. Note that there is also leakage channels on the basolateral aspect. So you can either bring in that potassium back into the interstitial fluid to reuse it here. So basically you have this cycle right here. Or you can, because potassium concentration is high inside the cell, you can basically leak it out or diffuse it out into the filtrate. Now, if you guys recall back from beginning of the previous PowerPoint, we mentioned that when you want to form urine, urine is actually produced through three separate processes: filtration, reabsorption, and secretion. So reabsorption is taking molecules from the renal tubules and return them back into your blood vessels, right? Now, secretion is literally defined as reabsorption in reverse, which means molecules are going to move from your bloodstream back into the renal tubules and eventually be eliminated from the body. Now, what are the components that can be secreted? Again, depends on the body. It could be potassium, hydrogen, ammonia, um, organic acid, bases, bicarbonates, anything that your body doesn't require and it's extra, it could be basically returned to the body throughout the renal tubules and excreted as part of urine. Secretion include also a lot of drugs that are going to basically not be used by your body. So urine is a very good way of removing that extra the excess dosage of the drugs. Undesirable substances, so you can also secrete urea if you have way too much of it in your bloodstream. Excess potassium is another one, as we mentioned earlier, and we discussed the acidity and alkalinity of the blood. If your blood is acidic, you want to reabsorb, you want to secrete hydrogen and uh, produce and reabsorb bicarbonate. And if you're alkaline blood, I didn't mention chloride, but you're reabsorbing chloride instead of bicarbonate, and you're also going to bring in hydrogen ions. So that is the end of your urine production. So those are the three processes that basically help you produce urine in the renal tubules and, well, inside your nephron. And you please do pay significant attention to what happens in each segment and be able to draw these. So I can as easily in your exam ask you draw a PCT and represent the type of molecules that will be moving or reabsorbing in your PCT, and you should be able to recreate anything that I have discussed with you guys so far. Now, we're going to switch gears and go to the third PowerPoint and focus on how your urinary system is maintaining balance within your body using hormones and enzymes and the auto regulation within the kidney. So let's introduce the concept of glomerular filtration rate. So that simply means the amount of filtrate that is being produced by your kidneys in every minute. Filtrate that is being produced every minute. Now, how do we determine the rate per minute? Some of the components that affect it is net filtration pressure, which we discussed earlier. It's about 10 millimeter of mercury in average, pushing fluid out. But I can change and control the filtration rate, net filtration pressure, by adjusting the diameter of the afferent and efferent arteriole. So I'm just going to do a quick drawing for you guys here. So if you guys remember, we had the glomerulus, we have the afferent and glomerulus, and we have the efferent. So notice in this picture that I've drawn my afferent much larger than my efferent blood vessel. It is very similar to what we discussed for the lymphatic system. So I'm going to bring a lot of fluid in, but I'm going to bottleneck it at the efferent arteriole, so the fluid will not go out as fast, okay? So basically this creates the pressure here that allows the fluid to move out, okay? So afferent arteriole is going to be larger in diameter compared to your efferent arteriole. Now it says I can change the pressure by basically changing the diameter of these blood vessels. And we'll talk about that in more detail in a few slides. But understand that the blood pressure, the blood vessel that is going to be changed more significantly is going to be your afferent arteriole. You really don't have much control over the efferent. Afferent is the one that is either going to be vasoconstricted or vasodilated depending on the condition. Total surface area of the filtration is basically distances between the podocytes that open up the space and basically allow the fluid to go through the glomerular capillaries. Filtration membrane is basically the permeability of the capillary network itself that also controls how much fluid can pass through. Now, let's continue by discussing regulation of the glomerular filtration. So let's say you are in a scenario where your body has produced way too much urine. Okay, well, sorry, let me back up. Let's say we have a relatively high glomerular filtration rate. That simply means you're creating more filtrate in 1 minute. That means that more of that filtrate is going to become your urine, and as a result, you're losing more water, therefore your blood volume is gonna decrease. Opposite can be true. If your filtration rate for your kidneys is slow, basically let's say your urine isn't functioning as well, the GFR, the rate of filtration per minute, declines, which means you will not be producing as much urine, which means there would be an increase in your blood volume. So logically, more filtrate means more urine, means less blood, right? And less filtrate means less urine, which means the water stays in your system, so there is going to be a larger blood volume. Now, the question is, I'm just telling you GFR is high, GFR is low. But how do I maintain this GFR based on the body, based on the requirement of the body? We actually have two main systems of balancing and maintaining GFR. One is referred to as intrinsic controls, which basically means in the house. So you are auto-regulating yourself. And the other one is known as extrinsic control, which you rely on outside control system to basically control and maintain GFR. So if your fluctuation in the GFR is not significant, then your intrinsic control, your kidneys, is going to do the job. So basically, it's minor changes, and it says, okay, I can take care of it. But if the changes are significant, so there is a significant change in blood pressure that could significantly affect GFR, your kidney is basically removed from its position of autoregulation, and you pass that responsibility to either your nervous system and or to your endocrine system, which are basically your two control systems inside your body to help you maintain your GFR, and through that maintain your blood volume, and again through that maintaining your blood pressure. So for this one, I'm just gonna go over the intrinsic control system, the first one, and then we'll continue on the next one later. So let's say there is a decrease in the blood pressure, the pressure that is within the afferent arteriole. So remember, your blood vessels that supply your nephron was the afferent arteriole. So I'm just gonna quickly draw this. So you have this whole drawing that I did. Afferent is the big one. You have your glomerulus, and then basically this goes out, right? Afferent and efferent. Efferent. So in this scenario, they said there is a decrease in the afferent arterial pressure. So there is a decrease in blood pressure here, which means you're not going to push the fluid as strongly out this way, right? So let's say if your pressure was at normally at 10 millimeter of mercury pushing out, right? Let's say it drops to 9. Okay, so you drop it to 9 instead of the original 10 net filtration pressure. Now that means that the fluid that there is a decrease in your GFR because there is a decrease in your GFP. Think about it. Pressure drops, which means the rate of filtration also going to drop. Now, what is the way that I can handle this? All I need to do is make this blood vessel bigger. So afferent artery is going to get bigger. When I open up these blood vessels, you're going to push more blood into the glomerulus, right? More blood means higher pressure. Higher pressure means higher filtration rate. So, if I have, let me repeat this one more time. If I have normal amount of blood, there is no bleeding, there is no significant dehydration, there is a slight decline in how much GFE my kidneys are creating through the afferent arteriole, let's say dropping a little bit. So as a result, your net filtration pressure is going to drop, and when net filtration pressure drops, your rate of filtration also drops, correct? Now, one way for me to resolve this without relying on any outside sources is to dilate, make my afferent arteriole larger. So I'm going to cause vasodilation on the afferent arteriole. Vasodilation means more blood, is going to come in through my afferent arteriole and through my glomerulus. More blood means more pressure, and higher pressure means higher rate of filtration. So if you can see, it says increase in GFP causes an increase in GFR, which means you're back to normal. Now what I'm doing is basically I'm controlling the smooth muscle that are around the afferent arteriole and stretching them to cause vasodilation. Oh, sorry, I should say decrease the stretching on them to cause vasodilation. So this concept, because it's dealing with muscle, I'm going to use the word myo. Remember, myo means muscle. So myogenic means basically mechanism that uses muscles. And because my kidney is doing it without the help of anything else, it's considered to be autoregulation or self-regulation. Now, this process can be reversed if your blood pressure is too high. So if your blood pressure for your, let's say, your aorta is too high, that means systemic blood pressure is too high, which means net filtration pressure is high, which means the rate of filtration is high. I'm pushing too much water out. I don't want that. So what is my solution? Make these blood vessels smaller, stretch them, make it smaller. If this is a smaller, that means your pressure inside the glomerulus is a smaller, which means rate of filtration is also going to be smaller. This is one of the two of the intrinsic systems inside your kidney. The second one is referred to as tubuloglomerular mechanism of autoregulation, and I will talk about this in our next presentation.